Intermediate uveitis. It is a chronic relapsing disease of insidious onset in which the vitreous is the primary site of inflammation. It incorporates the following entities. Number 1, pars planitis. Second, posterior cyclitis. Third, hyalitis. So these three are the entities in intermediate uveitis. The diagnosis is made clinically. The intermediate uveitis may be idiopathic in at least half of the cases or associated with a systemic disease. Pars planitis is the term used for a subset of intermediate uveitis in which there is snow banking and or snowball formation, but only if the inflammation is idiopathic, that is, with no identifiable underlying infection or systemic disease. Otherwise, the term intermediate uveitis is used. Intermediate uveitis accounts for up to 15% of all uveitis cases and about 20% of pediatric uveitis. A minority of patients have a benign course with spontaneous resolution within several years. In other patients, the disease is more severe and prolonged with episodic exacerbations. Intermediate uveitis associated with systemic disease has a variable course. Now, the clinical features, symptoms. The presentation is with the insidious onset of blurred vision, often accompanied by vitreous floaters. There is usually no pain or redness. Though initial symptoms are often unilateral, objective findings are typically present asymmetrically in both eyes. Visual acuity is variably affected depending on the inflammatory activity and complications, particularly cystoid macular edema. The disease may last as long as 15 years, and preservation of vision will depend largely on the control of macular disease. In follow-up of up to 4 years, 75% of patients maintain a visual acuity of 6/12 or better. Anterior uveitis. In pars planitis, there are few cells and small scattered capi, which is occasionally have an inferior linear distribution. In other forms of intermediate uveitis, the anterior uveitis and its associated findings such as posterior synecdoche can be more prominent, especially in children and in sarcoidosis and in Lyme disease. These are more prominent, the posterior synecdoche and anterior uveitis. Now the vitreous cells with anterior predominance, as shown in this picture, they are universal. Vitreous condensation and haze is found in severe cases. These are the grades of vitreous haze. Grade 0, when there is good view of the nerve fiber layer. Grade 1, when there are clear disc and vessels but hazy nerve fiber layer. Grade 2, when the disc and vessels are hazy. Grade 3, when only the disc is visible. Grade 4, when the disc is also not visible. Snowballs are whitish focal collections. So there are snowballs. These are whitish focal collections. So snowballs are whitish focal collections of inflammatory cells and exudate, usually most numerous in the inferior vitreous, as shown in this picture. And there is peripheral periphlebitis. It's common particularly in multiple sclerosis. Careful examination of a normal fellow eye in apparently unilateral disease may reveal mild vascular sheeting. Snowbanking is characterized by gray-white fibrovascular and or exudative plaque that may occur in any or all quadrants but is most frequently found inferiorly. Neovascularization may occur particularly in the retinal periphery, often associated with snow bank, and on the optic nerve head. When the optic nerve head is involved, it usually resolves when activity is controlled. This can sometimes lead to vitreous hemorrhage, retinal detachment, cyclitic membrane formation. Focal peripheral retinal vasoproliferative tumors are uncommon. Vitreous hemorrhage is more common in children. Optic disc swelling is common especially in younger patients. CMO occurs in up to half of the patient and is the major cause of impaired visual acuity. Macular epiretinal membrane formation is common. Also, cataract can be caused by steroid treatment or by the inflammation itself. Glaucoma may occur in eyes with prolonged inflammation, particularly if receiving long-term steroid therapy. Retinal detachment is generally uncommon, but as it can progress to hypotony or phthisis in advanced cases, prevention should be a major goal of management. The etiology may be tractional, rhegmatogenous, occasionally exudative. Phanoschisis has also been described. So when there is insidious onset of blurred vision accompanied by vitreous floaters without pain or redness, it suggests a possible diagnosis of intermediate uveitis. Investigations. Inflammatory markers such as ESR and or CRP should be checked, together with a complete blood count, as they may raise suspicion of a systemic inflammatory process. OCT is a key to excluding subtle cystoid macular edema, and fluorescein angiography will help in assessing severity. Other investigations are targeted at the exclusion of an underlying cause as below. Number 1 is multiple sclerosis. Inquiry should be made in all patients about neurological symptoms, noting that IU may precede other symptoms of demyelination. MS should be suspected in patient aged 20 to 50 and is twice as common in women. Granulomatous AIU may occur. Cranial MRI imaging should be performed if any suspicion is raised. So this is systemic disease can occur in 1/3 of patients. In one study of 82 patients, 10 had sarcoidosis, 6 had multiple sclerosis, 2 had optic neuritis, and 2 had IBD. Sarcoidosis is relatively uncommon and is with MS may antedate the onset of systemic disease. The presence of associated granulomatous anterior uveitis should arouse suspicion. A serum ACE level chest X-ray should be performed in all adult patients. Lyme disease associated IU is often associated with severe anterior uveitis. Serology should be performed in individuals from an endemic area. Syphilis serology, treponemal and cardiolipine antibody tests should be performed. Tuberculosis is an uncommon association that may give respiratory symptoms demonstrated on chest X-ray. Tuberculin skin test and or blood quantiferon testing should be performed prior to steroid treatment in the presence of any suspicion. Other conditions that may give vitritis mimicking IU include FUS, intraocular lymphoma in older patients, toxocara granuloma, Whipple disease, endogenous candida endophthalmitis, risk factors such as in IV drug use, and toxoplasmosis. These will commonly be suspected on the basis of history and specific clinical findings. Treatment: an identified infection or other underlying disease should be treated specifically, supplemented by anti-inflammatory measures. Many authorities aim to abolish all active inflammation regardless of whether vision has been affected. Factors such as presence of peripheral neovascularization may prompt earlier intervention. Topical steroids do not reach the posterior segment in high concentration and therefore have a limited role. This medication is used mainly to treat any anterior segment inflammation. It has been proposed that in mild IU, a course of frequent topical steroids of a few weeks' duration may exert some benefit and identify individuals at high risk of IUP elevation without committing to the extending action of depot injection. Regional steroid injection at the orbital floor or posterior subtenon injection is described for anterior uveitis. Depending on severity, injection is performed 4 to 6 times at intervals of 2 to 4 weeks, accompanied by IOP monitoring. NSAIDs, if inflammation persists after regional injection, an agent such as naproxen 500 mg twice daily can be commenced. Cryotherapy, double freeze thaw to the pars plana and retinal periphery under the peribulbar anesthesia can be highly effective if inflammation is steroid resistant and may be appropriate prior to systemic steroid. It can be associated with transiently increased vitritis and other complications including retinal detachment, cataract, vitreous and hemorrhage, epiretinal membrane formation and hypotony. Repeat application may be needed after several months. Some authorities reserve cryotherapy for peripheral neovascularization with hemorrhage. Peripheral retinal laser adjacent to snow banking and to ischemic areas. RFA is an alternative to cryotherapy and may be as effective with a lower rate of complication. So it should be done adjacent to snow banking and or to ischemic areas. Intraocular steroid, intravitreal triamcinolone has been shown to benefit, but the effect is of relatively short duration. Slow release implants have demonstrated promising results. So dexamethasone 0.7 mg intravitreal implant in the name of Ozurdex. Sustained released fluocinolone acetonide 0.19 mg or 0.59 mg intravitreal implant. Systemic steroids this modality is preferred over regional steroids by some practitioners if symptomatic inflammation is bilateral. Others prefer to avoid systemic steroids in most cases, proceeding directly to immunosuppressive chemotherapeutic agents. A large dose of 1 to 2 mg per kg per day is commenced, tapered slowly over months according to response. It is essential to consider the contraindications and potential adverse effects of steroids before prescribing. Immunosuppressive agents, mycophenolate, methotrexate, tacrolimus, cyclosporine, and other alternatives in steroid-resistant inflammation are as steroid-sparing. Other agents demonstrating efficacy in the refractory disease include interferon beta in MS-related IU and the anti-TNF infliximab, mycophenolate and methotrexate. Pars plana vitrectomy reduce inflammatory intensity recurrence, though the mechanism is imperfectly understood. It is indicated in patients with tractional retinal detachment, epiretinal membrane refractory CMO, dense vitreous hemorrhage, dense vitreous opacity, and substantial peripheral neovascularization. Cataract and glaucoma are managed medically and surgically if necessary.